Thank you for joining us today at ESMO 2018 Munich for this OncLive event. I'm David Gandera. I'm a professor of medicine at the University of California, Davis Comprehensive Cancer Center, where I'm director of the Thoracic Oncology Program. Joining me today as faculty is Everett Volks, who is professor of medicine and radiation oncology and chair of the Department of Medicine, physician-in-chief at the University of Chicago. So we're really delighted that you've joined us today. We're going to be discussing advances in thoracic malignancies, specifically lung cancer. There's been so many advances within the last 2 to 4 years. It's really unprecedented. I don't think there's anything like it in the history of oncology, not in any other cancer type. So there's a lot for us to discuss today. We're going to start by discussing some of the advances in immunotherapy. This has been either a tsunami or an earthquake, depending on where you live. And we'll talk about how the advances have gone into first-line therapy. So Everett, of course, one of the issues, and I'm sure our audience today is going to be most interested in how we're incorporating the new data regarding immunotherapy monotherapy first line, or when would you use an immunotherapeutic agent together with chemotherapy? What biomarkers, if any, are you going to imply? So what are your thoughts about the recent studies, including those presented this morning here at ESMO?
So David, thank you very much. I agree. It's been a tsunami. You could also talk about a sprint, because things have developed very, very quickly in a sports analogy. And what we have is so complex of a data set that even for us as experts, we have to try and remember the names of the trials and the specific makeup of the trials and the numbers. But I think what's very clear is that we now, in first-line treatment for non-small cell lung cancer, using that term still, have a complete reversal of what was standard of care just a few years ago, namely doublet chemotherapy, and that for the majority of patients, it has become doublet chemotherapy plus an immune oncology drug. I would say that we now have a choice there between atezolizumab and pembrolizumab, with, in my mind, the most solid data probably being there for pembrolizumab. And then we have to differentiate the group of patients that we want to expose to 3 drugs versus the group of patients we want to expose to a single agent. And that's where you and your particular expertise really with biomarkers also come in. So to summarize very briefly, we have for pembrolizumab Keynote 189, which looked at the addition of pembrolizumab to standard chemotherapy. And that is a published paper in the New England Journal showing both progression-free survival and overall survival improved across biomarkers, really. And then for atezolizumab, it's a little more complicated because really there are 3 trials. Empower 150, which has been presented the most thoroughly and is the most complex to describe. But the control arm is carbotaxel and bevacizumab, and the experimental arms either add to that atezolizumab or substitute bevacizumab with atezolizumab. And the PFS and survival are positive for the bevacizumab arm, but only trending for the non-bevacizumab arm. And then there is Empower 132, which is very similar, looking at carbo or cis and pemetrexed, plus minus atezolizumab. And that was again shown this morning with subset analysis, showing progression-free survival, but if I recall, not yet survival as statistically significant, but trending positively. And then the last trial is carbo and cis and nab-paclitaxel plus minus atezo, also shown this morning, and showing a favorable outcome for PFS and overall survival.
So
it's a
lots of
complex
choices
set,
now.
and you know, I'm just trying to remember, and looking at you for affirmation to make sure I got it right. So, but
So
that's where I think we are.
This morning we were feeling empowered.
Yes, absolutely.
Because several of the Empower trials were being described.
Yeah.